So I gave you some stuff this morning to process. Before we go on, any questions on any of that material?
I was trying to find out about the different, on the question, the spinal cord syndromes, anterior, posterior. It was one of the case study questions.
It was one of the case study questions?
Yeah, but I was trying to see where that...
The purple.
Particular... And then I guess I could look at brown squad.
Which one? The browns? No, we did not discuss that. I don't think you have anything with that on there.
Okay.
So I think you're good, because I don't think it's in this book, from what I saw.
Gotcha. Yeah, I didn't either. Okay.
Okay. All right. So this one, Chapter 44, Care of Patients with Problems of Peripheral Nervous System. With this, it does not match up to the new book. Okay? So the information hasn't changed, but this is an older book, and I did not make new slides. Okay? So keep that in mind. You might be taking a lot of notes. Okay? Because the thing is, things that were in the old book are still just as important. They may not have the same emphasis as the things in the new book, but they are still very, very important.
And you will see them on NCLEX, more importantly.
Yeah, most importantly, NCLEX, you will see those. Things that we've talked about before, as far as the primary concepts, like for NCLEX, mobility. So how are they able to move? Are they able to sense? Or their immunity. And that's where we're going to talk about Guillain-Barré syndrome. Another thing that had been talked about in the previous chapter was gas exchange. Because if they're not oxygenating and they're not able to exchange gases in the proper way, that's definitely going to affect our neural system in the brain. Okay, this is important. In our book, the new book, it's on page 834, and there's just a little tiny bit. But, so you'll have more even on this slide, okay? So, what happens with Guillain-Barré is the demyelination of the peripheral nerves, and it's a result of an immune-mediated pathological process. It's rare, and it's an acute inflammatory phase. Okay, when this happens, the ascending muscles become very weak, and they can have pain with it too, but the ascending paralysis. So it starts at the bottom, and then it will come up the body. So if they can't feel their feet, are they going to live? Yes. If they can't feel their legs and they can't walk anymore, are they going to live? What if it goes up into the abdomen? Are they still going to live? It starts to get more problems, right? Because we're getting into the kidneys, we're getting into the bowels, and we're getting into more problems. But when it comes up to the lungs, and the lungs can no longer move, which means we can't do what?
Breathe.
We can't move air, we can't breathe. And what's most important? Airway. And so if that becomes paralyzed, what will they do? They will die. So we have to make sure. So the most important thing with Guillain-Barré is the respiratory status. That's when it gets worse for respiratory failure. Now, so the patient's going to rapidly change. As a nurse, what we need to think about, what kind of checks are we going to be doing on this patient anyway? What kind of assessment specifically? What are we studying? Neuro. We're going to do our neuro assessments, okay? So for this patient, we're going to do them every hour while things are still changing. If they start to stabilize, then we can go to Q2 to Q4, and then we can go up to per shift, okay, once they've stabilized out and things haven't gotten worse. This is not something seen a lot, but it is out there, and you will come across it. But what has happened, I think I've in previous lectures told you about a patient that I know of personally with this. What caused it? What was the COVID? What do we find with COVID? Affects the cranial nerves, right, too? As far as people lose their sense of taste and smell. Okay, so that's one thing with the nervous system. This is another, and we're going to talk about another disease, but yes. So a patient had COVID. They were hospitalized, not doing well. This is my son's new father-in-law. This is actually who it is. And after that, guess what happened? He went home, and then he started to have trouble, couldn't feel his feet, having trouble walking. Went in, and that's what he had, this Guillain-Barré. Okay, but it was post-COVID. It was post-viral. Causes our immune. Okay. All right, things we're going to be noticing. We're talking about the loss of reflexes in the arms, legs, muscle weakness, paralysis, numbness and diplopia. What's diplopia? Double vision. Yes. Okay. And part of this, the diagnostic assessment, there's no single test. We can use a lumbar puncture. The electrophysiologic studies, an EMG or an MRI can help with the assessment. This is a very rapid progression, and that's why we were doing neurochecks 1 hour in that active phase. And what they found is that the antibodies attached to the myelin sheath, a lot of times it's related to a bacterial infection. Okay. Okay. Potential for which is our biggest one up there. They're all important. Respiratory. Those for respiratory or cardiovascular distress. Failure due to thoracic muscles weakening and hypotension. Hypotension is going to be related to the cardiovascular. If our heart's not doing great and we don't have great blood flow and how's our skeletal system going to work, right? With these patients, we said it was potentially fatal, but if their blood pressure goes down and the heart rate goes down, they become bradycardic. When you're getting your lower and lower heart rate, sometimes they'll go into a heart block. Heart block then leads to asystole, that nice flat line, and then of course to death. The good news is 85% recover. So if it's caught in time and we can treat it, so if the patient's having trouble breathing, what will we be doing with them before it paralyzes? We're going to put them on a ventilator. They will be intubated, and we'll do the breathing for them until their body can do it on its own. So that's why we have to catch it in time. Okay, so we're going to prevent the respiratory or cardiac distress. Plasmapheresis. So we're going to go ahead and remove the circulating antibodies that they think are causing it. It does usually replace itself, but we can also give the patient plasma or albumin. We're going to try to increase their mobility and prevent complications. Physical therapy and occupational therapy are truly great friends of yours. You want to be in consistent communication with all your team members when you're at the hospital. It's hard enough to have your team of patients, but when you do, if you have a good relationship with that physical therapist, and instead of you getting that patient up by yourself or waiting for your tech to help you, if you need more help, if you catch the physical therapist in the hallway, you can say, hey, what time are you headed to room 410? What's your schedule, and when are you going to hit 412? And then you can work with them to at least get the patient up, then they can start exercises, and you're working in conjunction and with. And guess what? Physical therapy would be happy about that too. Okay. All right. Myasthenia Gravis. Guess what your book has on this? zilch, nothing. The new book has absolutely nothing. Okay? But this is still something that will be on your test. I did not run the sheets. I started to, and I got sidetracked. I am so sorry. There it is. And they will come. Yes. That'll work.
So there's 2 pages.
Well, actually one, because the bottom is ALS. We've already talked about ALS. That's the only one that we have not talked about. So we will come back to this, because then you'll have a handout, because it will be discussed. Restless Leg Syndrome. And this one is also not in the book. But you've got the slide. I think you'll be fine with this. Leg paresthesias. So they are moving these legs, and they're not trying to. Has anybody seen anybody with restless leg syndrome? Michaela has? Caitlin has? Is it anybody you know closely, or is it a patient? Uh-oh, you do. Do you mind sharing with us about it?
It's really irritating. It gets worse at night.
Worse at night?
I just get like this really bad, like itchy feeling, and I have to move my leg. I have no choice.
You have no choice but to move your leg.
Just to relieve, and I can't really bad. And my husband hates me.
I was going to say, does your husband tolerate that well? Usually the spouses, it's not a fun thing.
And it's because mine started whenever I follow my tailbone a lot.
Uh-huh.
And I like have stenosis and stuff like that, so they make me stiff for that, all my lumbar issues.
Okay. Well, peripheral and central nerve damage in the legs or spinal cord. Bam. So from those falls, you can really tell the difference. Okay, Michaela. You have it too? You have any different symptoms than she does? Because not everybody's symptoms are all identical. Just drive you crazy. Now, okay. I was going to say, I don't think you have a spouse. I don't know, but I don't think so. Okay. So hopefully you haven't drove somebody crazy with it yet. Does it wake you up at night? Does it wake you up and keep you up? Okay. Do you ladies take anything to sleep at all? Sleeping aid at night? Any, what kind of things on clinical are we giving our patients to sleep at night? Melatonin. Now, but we only take that at night, not in the morning, right? Well, definitely not before you go to class. That would be really bad. All right. What kind of things can we do for treatment for our patients besides medications? Medications would be like Neurontin, Valium, Integratol. I'll say this one more time, Neurontin. I think we've given that a lot in clinical to almost all our post-surgery patients. Valium, Integratol. Things we want to do to help the patient themselves is to make sure they're getting a lot of stretching in. And doing a lot of walking will also help, because you're keeping those nerves, keeping the circulatory system going with those really well, keeping them fed. We are supposed to avoid caffeine and alcohol. Thank you, dear. Thank you, thank you, thank you. Did you remember the number that I still have in my head that you gave me earlier? Did you remember the number that you gave to me earlier?
No, just use mine.
That's why I'm just teasing you. She even tried to help me with this before, and I didn't get it done. That's why I was just teasing. All right. Trigeminal neuralgia. Now, this is in your book, but not to as the extent. It is on page 833, trigeminal neuralgia. All right. There's another name for this that people will call tic de la rue. And I didn't know that until a couple years ago. One of my girlfriends was telling me, I'm like, what? Now that's called trigeminal neuralgia. Did you get one? Everybody get one? Okay. Yep, thank you. So tic douloureux is another name for it. And this affects the trigeminal or the fifth cranial nerve. And this, I told you in a previous lecture, but this is also called the suicide disease. This pain is so severe, and we have to take care of the pain management. The pain is so severe that people are, I'm done with this. They can't get rid of the pain, and they don't want to live like that anymore. This is where there's excessive firing of the irritated fibers. And I want you to think it's a very sharp, and it can be a very sharp chronic pain, but it's like sparks or shocks. Okay? And the reason I know this so well, it's typically in females more than males. Okay? And what happens is it's most common after there's been a certain jolt or head injury or forcing. And so that's when mine happened, after I got bounced across the room by a patient that was on drugs. After that, came back. My vision was messed up. I mean, I couldn't fix my vision to try to read the computer in my right eye. And they're like, Sally, what's wrong with your face? And I'd be like, only it was much worse. Okay? But I had pain. My whole side of my face hurt. And then where I end up with it the worst, if I don't have rest, you won't see my contacts in like today. So I didn't rest a whole lot last night. But I would wake up, and it was almost like lightning bolts to this eye, just to try to open it up. And with the job I was in, even answered my cell phone in the dark at night, I could barely see when I was having such a difficult time with it. Okay? So even some of the drugs did not help. And what we finally had to do, because it was just my right side, is I'm on Timolol. Because the pressures in this eye are so irritated and elevated. Okay? But it is really, really, but I'm thankful I can do it with non-surgical management. Okay? And now that I'm at this much less stress job, I'm also doing much better. But rest is very important for these people. Surgical management. So they can go in and do a microvascular decompression, or sometimes they go with the radio frequency. They will go in to coagulate. Or they can do a balloon microcompression. My neighbor had that done. I said, I didn't even know. Yeah. I'm like, whoop. But that's not done very frequently. And she had went to a surgeon out in California. Can you imagine flying across the country because you hurt so bad? But if that was the only surgeon that could do what you needed, like I said, the pain is really tough from this. And our trigeminal nerve, if we look, it affects people differently. So this one, of course, is going up to our eye, out through our nose, and out through your jaw. And that's why you see the difference. If they try to smile at you, you'll only see one side up. Okay. I did have a patient that I admitted just this last year, and guess what he was? He was post-COVID. He had been in the hospital for COVID, and it was last October. He had COVID, I want to say at the end of August. September, he still had issues. And then he came back in October. And I admitted him because he now had the diagnosis of trigeminal neuralgia. Okay, so we're seeing all these neuro things after COVID. Okay, I have not had Bell's palsy, I'm thankful. Okay, has anybody in here had Bell's palsy? If you've seen somebody with it, you won't forget. They can't crease their forehead. It's always unilateral, one side. They typically cannot close the eye, which is a big issue. We have to keep that lubricated. And a lot of times we will patch the eye. Okay? But that affects the seventh cranial nerve. Medical management, we can use steroids, prednisone. Analgesics for the pain, and acyclovir. What's a cyclovir treat? What kind of drug is that? It's a antiviral. Very good. Okay. So protection of the eye, like I said, they may have to patch it on and off with the patch, or keep it patched depending, and make sure they can keep that eye lubricated because we don't want it to dry out. Still a mucous membrane. Nutrition's difficult. These people have a hard time eating because all of a sudden you can't move that side of your mouth, and then you're going to be, they don't want to eat in front of people because stuff will come out, you know. That's not very fun. So what do we have to train them to do? To help them to eat without, we still need them to have adequate nutrition. They still need to eat. But take the bites and put it on the side where they can chew. Okay? Massage can be helpful. Warm and moist heat. And different facial exercises. Now the thing with this, how long does Bell's palsy last? It's not typically a forever disease. It typically gets better. Usually the first 48 hours are the worst. Happens immediately. Then it gets better. Usually by the 2-week mark, they're doing much better and they don't have as much trouble chewing, that type of thing. And then usually they can get back to their regular lifestyle. I remember first time I saw this was a kid in my chemistry class in high school. I'm like, what happened to you, Dan? And he's like, I don't know. I got to wear this eye patch. But you could see the difference in his forehead, too. Like I said, because you can't crease the forehead, all of this whole side. It's kind of different. The other thing I did not tell you, I'm glad I wrote this down. There may be excessive tearing. They either don't have any tears or it's an excessive amount.
Sally,
Yes.
when you see somebody with Bell's palsy, a lot of times it mirrors a stroke.
There you go.
When you think about like the facial paralysis, the slurred speech, maybe drooling, Bell's palsy and the signs and symptoms of a stroke are very similar. Okay.
Thank you.
Sometimes patients may have residual, they regain some of that muscle control, the neurological control. However, if you look at them closely, that affected side, the eye may droop. When they smile, the corner of their mouth may not go up as high as the other side. Just at a resting state, their face, you may see that one side looks more droopy. Okay, so think of Bell's palsy as very similar to the signs and symptoms that you would see facially of a patient with a stroke. Okay?
Thank you, Jen.
So very, very similar. The watering eyes, the drooling, slurred speech, difficulty swallowing, all of those things.
Those great neural symptoms that we have with a lot of them.
And, with all of these, there's a psychosocial component because, we're in a state now where if I have some facial paralysis, I'm wearing my mask almost 24 hours a day. We don't see it, but pre-mask, there was a lot of psychosocial issues with patients. They're embarrassed. They don't want to see people. They try to isolate, that sort of thing. Because our face is who we are, right? So always think about that psychosocial component when you're thinking about the neurological disorders, because a lot of times that there's always going to be that damage. So there's a risk of a residual, kind of like when you have a broken bone. Okay, it heals back, but it's never going to be as it once was. So there always may be just a little bit of evidence that, I wonder why their eye's a little droopy, or their smile's crooked. I wonder if they've had nerve damage. And a lot of people are very, very self-conscious about that. Sorry.
No, that is fine.
It's my favorite, and I just can't say
I'm glad it's your favorite.
It's hard, when you've been a neuro nurse for 25 plus years, it's hard to take it out.
Oh, absolutely. And when she was talking about how they feel about themselves, we will talk about that a little bit with the stroke patients. You guys talked about it this last week when we lectured, how hard these diseases are. There's not anything very exciting, and it's very, very tough. You know, that mental status on all of them. You think the trigeminal neuralgia with the pain, it's called the suicide disease. These are very tough on these people. Very, very tough.
And always remember respiratory on all of these. Okay, and how do we measure that?
Respiratory? How do we measure respiratory? Right?
And? Pulse ox.
Pulse ox.
Yeah. 24/7, put them on a pulse ox, man.
Mm-hmm.
Because especially with GBS, we need to know. Because
Yeah.
that paralysis, they can be fine 1 minute, you walk down the hall, you answer a call light, you come back, and it can be that rapid.
Very quick.
Okay, so do not let alarm fatigue affect you. If you hear somebody's pulse ox going off, get in there,
Absolutely.
okay?
And that has even become harder with COVID, because if you're dressed up and gowned and taking care of a COVID patient, you can't always immediately get in there to your other patients. And that's why we have the pulse ox connected in with the telemetry monitors a lot of times. So your telemetry technicians will also let you know that this patient's O2 saturation is going down. Now, that telemetry monitor tech is only allowed to call the nurse. They have to call the nurse. Sometimes if they're off telemetry, they can call the tech on the floor. But because respiratory is so important, they call first the nurse. You know, and then, especially with COVID patients, they call the nurse and then they call RT. So there's times that we even have the others contacted. Not that the tech's not important, but it's something that techs have not been trained to deal with. Okay? All right, let's look at your paper here on Myasthenia Gravis. What kind? We've got an autoimmune disease. Okay? And it's affecting the neuromuscular transmission for the voluntary muscles of the body. The nerve impulses fail, and they do not pass the myneural junction. Okay? They're not secreting or using acetylcholine. And that's the big problem, not using acetylcholine. Can put the patient in a big crisis. Signs and symptoms we're going to have periods of exacerbation and remission, so kind of like MS. You know, a lot of these are similar for the fact they'll have this big exacerbation, it gets worse, and then it'll get better. But it's precipitated with stress and illness. Okay? The activity, the muscle weakness can be resolved with rest, generalized fatigue, rest. They're going to have the diplopia, which is what again? Double vision, impaired mobility for the face, difficulty chewing and swallowing. The other thing I want to say with chewing and swallowing, we have to be worried about what if they're having difficulty with that.
Choking.
Aspiration can lead to an aspiration pneumonia. We're going to get something down in those lungs, we can't get it out. That happens to a lot of the elderly, especially after strokes. But because they're not able to really, even if they're not able to communicate, all these patients with the neuro disease. Speech weakness, fading voice. They don't have any sensory loss, so they can feel if you're poking and prodding them. They're just weak, and they're not really able to do anything about it. Okay? So anybody with myasthenia gravis, what are we really worried about? Aspiration, respiratory insufficiency, and infection. Okay? Because we don't want to put them in crisis. Because when we put them in crisis, that's when we have the tinselling crisis. And it's going to be affecting their heart. Let me go back here. I have some other notes. It's going to cause some dysrhythmias. And if we, that's where we can go to a bradycardia. and then to an arrest. Atropine is the drug that we like to give if the heart rate is low, and that's what we'll give. The cholinergic crisis is when they have too much, and it's not necessarily going to be that helpful. We're going to go ahead and hold the anticholinergic drugs while they're on a ventilator. And the myasthenia crisis, that's the startup of their symptoms. And we just really have to keep respiratory first. Okay? Same type of things, plasmapheresis. So we'll get that off of the plasma. We'll get it dialed out. Respiratory support. Nutritional support, eye protection. Surgical management involving a thymectomy. What are we getting ready? What's it? Getting rid of our thymus gland, it says right here. Okay? Getting rid of the thymus gland. Where's that located? Anybody know where your thymus gland is? There you go. Very good. All right. So I think that's what we need to know. Assess for an upper respiratory infection. Blend their food or things that they can swallow easy. Suction available. Tube feeding if needed. And frequent rest. There is also a support society for them. Okay. Avoid overheating, crowds, overeating, changes in the sleep habits, or emotional extremes. What was another disease that I said you have to avoid the heat? MS. We'll wear them out quick, fast, and in a hurry. All right, let's head to our case study here. All right. Peyton, you want to read one for us today? Yep.
20-year-old female college student presents at the university health clinic with manifestations that include fatigue, muscle aches, numbness and tingling, double vision, and difficulty swallowing. The patient is transferred to an acute care facility with a diagnosis of
Rule out.
Myasthenia Gravis. Which diagnostic test would the nurse expect to be performed?
R/O is to rule out. You'll see that a lot in charts. So they're not giving her the diagnosis of myasthenia gravis, but they're thinking it might be that. So when we do rule out, we can say, this is what we're thinking, but that doesn't mean that we're going right down that path. Okay, what kind of test would we do for her? Okay, respiratory, what are we going to be looking at first of all as we're assessing?
Rate.
Respiratory rate, pulse ox. They might do a chest x-ray, right? Muscle ache and fatigue. What kind of blood work do you think they're drawing? Because our electrolytes are going to play a big important. Anybody that comes in with muscle aches, fatigue, we would definitely be checking their electrolytes. Numbness and tingling. Anybody with numbness and tingling, what do you think they're going to get? CT, CAT scan, computerized tomography, and especially with double vision because we'll be ruling out other types of things. Okay, so you guys have answers. Does it give you answers to this one? What's it say? Who wants to read them? Will you please? Thanks.
Diagnostic tests include thyroid function tests because excessive thyroid hormone is present in some MG patients. Serum protein electrophoresis to evaluate for immunologic disorders, and acetylcholine receptor antibodies because this test shows an elevation in most patients with MG. X-ray and CT scan for the thymus gland because some patients have a thymus tumor or hyperplasia of the thymus gland. Tantalum testing and EMG.
Okay, thank you. So we hit most of them, but the blood ones we didn't hit. Now, what were the blood ones again, one more time?
Thyroid.
Thyroid?
Electrophoresis.
Serum protein.
Serum proteins, because that'll tell us, and then we're checking their acetylcholine, right? All right, during the evening shift, the nurse notes that the patient is having difficulty mobilizing secretions. Which intervention should be implemented for this problem? Having trouble mobilizing the secretions. Which ones look good? C, coughing and deep breathing. I agree. What's chest physiotherapy? What is that? Does anybody know what that is?
Like dumping.
Like on the back, and you'll see this for a lot of pediatric. They will take and they will cup the hands. So if you're going to slap, it sounds like that. It's a different, but if you're going to cup, the cupping, try that on your leg. Cup it. Now if you just slap it, it hurts, right? But if you cup it, so they're going to go ahead and they'll start here, lower, and they'll bring it up off the back. So if this is my back, I'm going to start here. Does that make sense? Because what are you doing? You're bringing those secretions up. They will do that a lot on children. And they will be, even little ones, just, and you think they're hurting them, but you will still hear them this loud. Even on a little tiny baby. Okay? But it's not hurting them, as you can tell. But that cupping will give that sound, but it will be enough to get those secretions moving. All right, any other one that we could do? So we said C and B. E, the suctioning if needed. Absolutely. Would we consider plasmapheresis for this patient? Yes, we said we would, but it is not something that's going to affect the mobility of the secretion. Okay, during morning care, the patient's able to brush her teeth, wash her face, brush her hair. And then she gets exhausted after performing these actions. What is the appropriate nursing action? All right. Anybody want to say what it's not? I think sometimes it's easier. C, we're not going to document that she refused because she didn't refuse. That would totally be incorrect. And what about D? Keep going. You just keep going, keep going. No, we got to let them rest, right? So we're not going to encourage them to keep going. And do we want to do A or B? B is best because we're going to let them still try to do it themselves. If that doesn't work, then we can do A and help them. And you will see this not just with this patient, anybody that's fatigued. Some of you have been to cardiac and pulmonary rehab. And one of the things I want you to think about is when you're using your arms and legs like on an Airdyne, you're using more oxygen, okay? Pulmonary patients have a hard time with it. Pulmonary patients don't want to be there at 7 a.m. They can't breathe well enough. It takes all their energy to get there. So the pulmonary rehab class comes in the afternoon. And we do weights with them to put things above their head because once they wash their hair and get out of the shower, they got to sit 2 hours before they can get up and move. Just anything above the head and raising those arms really increases your oxygen demand, and it's harder for the muscles. It's easier if they're able to do stuff here, but you can't brush your teeth down here. You can't comb your hair down here. But all those things you have to have your hands up. So you'll see that also in hepatitis patients. They are so fatigued, they can't get their hands up. Go ahead.
The answer says it's A.
Says it's A. Provide assistance.
It says passive presentation of energy in the muscle movement. That increases when the patient is fatigued, which then limits her mobility and ability to participate in activity. Provide assistance as necessary to prevent the patient from becoming fatigued.
Okay. I'm not that nice to my patients. If I find the patient can't do it, yes. But yes, we can provide assistance. That's my physical therapy mind. Let's give them rest and let's try it again. Thank you for letting me know that, Nadia. That's why I said you guys have answers. I do not. Which I find quite different in the teaching world. It doesn't seem like that's the right way. Okay, continuing with the case study. Later that day, the patient asked the nurse about activities she can do after her recovery. Which activity will the nurse discourage? Same thing, sunbathing is the heat. We don't want to expose them to extra heat. She can wear sunglasses a lot of times. Anything neuro, we want to keep them in a dark room just because the sunlight hurts, or light in general. We can let her walk in her neighborhood and we can make sure she takes her meds. Is A correct? All right, we're good. 3 days later, she's stable. Plan is to go home. Oh, wait a minute, I thought she said she could be outside the neighborhood. These aren't in order. Where her mother will provide care for her. What things are necessary before she goes home? What do we think? Do we think A is an appropriate answer? Arrange for the special equipment in the home? Okay. What about arranging for home modifications, such as a ramp? That'd be good. Right? Should we teach the mother how to provide the physical therapy?
I mean, we could.
We could, but probably not essential. Teach family members how to use special equipment. If there is special equipment, or do we just arrange for the patient to go to rehab facility before going home? That will truly depend on the patient. But if we can get them home, it says we're discharging her to home. So that would not be the right answer. What does your computer tell us the right answers are?
A, B, and D.
A and D?
A, B, and D.
A, B, D. Okay. So we did get it. All right. Here's some more questions. Health history question. We'll give the nurse the most information when evaluating a patient for Guillain-Barré syndrome. Did you get the flu vaccine the past year? Has anybody else in your family ever had GBS? Have any of you ever been exposed to the Epstein-Barr virus? And have you had a respiratory virus in the past 2 weeks? Which one? I'm hearing C. It's D. Respiratory virus in the past 2 weeks. Like we said, it's usually post-virus. Okay? Bell's palsy patient. Okay, nurse caring for a patient with diagnosis of Bell's palsy. She understands that for a patient with Bell's palsy, the symptoms are the most severe during which time period after beginning?
B.
B, 48 hours after onset. Anybody disagree? Does the computer disagree? Okay, B it is. I did give you the right information there. 3, what other medical conditions would the nurse expect to see in a patient with restless leg syndrome? Diabetes and kidney failure, myasthenia gravis and decreased vision, trigeminal neuralgia and facial paralysis, peripheral vascular disease, and multiple sclerosis. D as in dog, correct? Peripheral vascular disease. Is that incorrect? What does the computer say?
I think it's A in the book.
In the book it says it's
Family history, diabetes, chronic kidney, iron deficiency, Parkinson's, neuropathy, caffeine, lithium, neuroleptics, and withdrawal from sedatives.
All right. Let's check this out because the book does not have anything about that in the new book. The old book has that. Okay. And is that the correct answer? A. Okay. So will you read that list real loud for us one more time? And thank you for having it open to that.
A family history, diabetes is puts them at high risk. Chronic kidney disease, iron deficiency, Parkinson's, peripheral neuropathy, caffeine, lithium, neuroleptics, or withdrawal from sedatives.
Nice. I didn't know the lithium one either. So diabetes, kidney failure. Good to know, thank you. So, especially since post-COVID we have all these neuro things, these are important to know. All right, that is the end of this one. Let's see if I can get that. Would you guys prefer a video? Have you already looked at all your videos? Would you prefer a video instead of more lecture, just for a little bit of a break? Yes? Okay. Anybody have a specific one they want? I would either say ALS or increased intracranial pressure. Let's see. Ice. This one or the ones below it? I'm sorry. Okay. Cannot be shown.
Open this, open this and it should open.
It's a short one, but it should be good. You can get it here.
This is Sarah with RegisteredNurseRN.com, and in this video I'm going to be going over increased intracranial pressure. And this video is part of an NCLEX review series over the neuro system. And as always, after you watch this video, don't forget to access the free quiz that will test you on this condition. So let's get started. First, let's start out talking about what is increased intracranial pressure. It is where the pressure that normally resides within the skull has dramatically increased. And this is a medical emergency. The patient needs treatment fast because as that pressure builds, it can actually lead to brain death. Now, how is intracranial pressure created within the skull? It's created by the cerebral spinal fluid, the CSF, the brain's tissue, and blood. And we can actually measure intracranial pressure whenever we are monitoring a patient who has this condition. They can place special devices either in the lateral ventricle or sometimes in the subarachnoid space, and it can tell us what those pressure readings are running. And a little bit later in the lecture, we will go into detail about those monitoring devices. So what is a normal intracranial pressure? And I would commit this number to your memory. So a normal ICP is anywhere between 5 to 15 millimeters of mercury. Now, if the pressure increases greater than 20 millimeters of mercury, the patient needs immediate treatment. So remember the number, 5 to 15. That's where we want our patient. Now let's take a closer look at the human skull. As you can tell, it is very hard, and it is limited on how much it can really expand when something inside the skull experiences a change that will lead to increased pressure within it. Now, inside the skull are 3 structures that I want you to remember that can alter intracranial pressure, because it's going to help us understand Monroe-Kelly hypothesis along with the treatment and everything for this condition. So those structures include the brain, the cerebral spinal fluid, the CSF, and the blood within the brain. And in the blue, you can see this is where the cerebral spinal fluid is. It flows around the brain and down through the spinal cord. Now, intracranial pressure is interesting because it fluctuates and it can increase depending on certain factors that influences it. So I want you to remember these factors, because whenever we're talking about nursing interventions and treatments, we're going to go back to these factors and see how we can intervene to help correct this increased intracranial pressure. So some factors that can alter increase intracranial pressure is body temperature. For instance, hyperthermia. If a patient's running a temperature, this can increase intracranial pressure. Also, oxygenation status, especially the carbon dioxide and O2 levels. If our patient is hypoxic, this can increase intracranial pressure. Or if their CO2 level is too high, this can cause vasodilation, which increases the cerebral blood flow to the brain, and this increases intracranial pressure. Also, body position can. So as the nurse, we want to make sure we are aligning our patient's body correctly so we don't increase intracranial pressure, like keeping their neck midline, we don't want it flexed, and keeping them at a certain angle, 30 to 35 degrees. Also, arterial and venous pressure can affect it, and anything that increases intra-abdominal and thoracic pressure, like vomiting, bearing down, or even flexing their hip, can increase that pressure in the abdomen, which in turn increases intracranial pressure. Now let's talk about the theory on how the body tries to compensate for whenever a patient is experiencing increased intracranial pressure. Well, to do that, we have to talk about Monroe-Kelly hypothesis. You really can't talk about intracranial pressure unless you discuss this, because it gives us our pathophysiology on how really this condition is happening. So what it says and what it deals with is how the intracranial pressure is affected by those three important structures that we just went over. The cerebral spinal fluid, the brain's blood, and tissue. And these three structures work together to maintain the cerebral perfusion pressure, the CPP. And I want you to remember that term because it's really important whenever we're talking about increased intracranial pressure, and we're going to discuss it in depth here in a moment. So, what does this hypothesis say? In a nutshell, what it's talking about, it's saying that if there is an increase in volume of one of those three structures that we just talked about, the other structures that aren't being affected are going to have to decrease their volume to help alleviate that pressure that is building. And how does it do this? It can do this by taking that CSF, the cerebral spinal fluid, and moving it somewhere else in the brain or in the spinal cord. Or it can affect the cerebral arteries and cause them to perform vasoconstriction, which is going to decrease cerebral blood flow, which is the amount of blood going to the brain tissue, which whenever that happens, that helps decrease intracranial pressure. However, the body can only do this up to a certain point. And if this pressure continues to build, it actually gets to the point where the body will start making things worse and will actually lead to what's called Cushing's Triad, which we're going to talk about whenever we go over our signs and symptoms. So now let's discuss cerebral perfusion pressure, CPP. What is it? It's the pressure that pushes the blood to the brain. So hence, it's going to influence the cerebral blood flow, the CBF. So in other words, in order for blood to get to that brain tissue, there has to be a proper pressure in place, which is the cerebral perfusion pressure. And what does that pressure have to be in order to get a good amount of blood to that brain? It has to be between 60 to 100 millimeters of mercury. And I would remember that number along with how we remember the normal ICP. Okay, so when cerebral perfusion pressure falls too low, the brain is not going to perfuse and brain tissue will die. So really, anything less than 50 of a CPP is bad, and we are probably going to lose some brain tissue. The brain is not being perfused. So since we know what cerebral perfusion pressure is, let's talk about how we calculate it. How do we figure it out? Well, we use this formula. Cerebral perfusion pressure is equal to the mean arterial pressure, the MAP, minus the intracranial pressure. And to figure it out, you have to know some things. You have to know the patient's blood pressure and what their intracranial pressure reading is. And usually you can get this from whatever monitoring system they have in place. So let's calculate it out. First, we have to figure out the MAP, the mean arterial pressure. So to do that, what we're going to do is we're going to take the diastolic, which is 42, and we're going to multiply that by 2. 42 times 2 is 84. Now we're going to take 84 and we're going to add it to the systolic blood pressure. That's the top number. So it's 90. So 84 plus 90 is 174. Then we're going to take 174 and divide that by 3. And
Okay. I'm going to stop that there.
When my daughter Amy was young,
The one
I'd take
thing,
her fishing. She would always say,
all right, I want you to keep in mind, the book says intracranial pressure is, what did I give you earlier? 10 to 15. They said 5 to 15. So, test purposes, I believe 10 to 15 is your number. You want to make sure you know. The other numbers, we don't have to remember from that. But she started to get to Cushing's Triad. There are questions on Cushing's Triad. That is in your book. But the things I want you to remember with Cushing's Triad, because Cushing's Triad is very important. As your blood pressure goes up, suddenly your pulse goes down, and your respiratory rate goes down. And the other piece is the blood pressure between your systolic and your diastolic. They get farther and farther apart. Okay, so let's just say we started at 120 over 80. To get the widening pulse pressure be 130 over 70 or 140 over 60. You see what I mean? So it's getting farther apart, and the blood pressure's going which way? Up. And what's our pulse rate doing? Down. And a respiratory is going which way? Down. And that is considered a medical emergency. Okay? All right, so Cushing's Triad, the 3 things. Blood pressure goes what? Up. Pulse goes. And what else goes down? There you go. All right, let's give you a little bit of a break. Okay?